Can you hear me?
Yes.
Yes.
Okay, all right. Yeah, please, yes, can you start? Can we start, guys?
Sorry, I cannot find my slide. Can you all see my slide?
Yes.
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 So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. I bid to Dr. Salehin and fellow friends. So today we are going to present a seminar on dermatology. So my name is Siti Nur Akila. So I will be presenting about the first topic, which is hemangioma. So firstly, we need to know what is hemangioma. So hemangioma is a benign vascular tumor that is characterized by early proliferation and followed by a spontaneous involution. So it can present at birth, but usually arise in first or second week of life, and it rapidly enlarge and spontaneously goes away. So most of it clinically resolved by the age of 9 years old. So although it is a benign lesion, there may be a risk of functional compromise or permanent disfigurement depending on the location and extent of the lesion. So, and it is the most common benign vascular tumors of infancy, and it predominates in female. Hemangiomas can be classified into superficial, deep, and mixed. So the superficial hemangioma is the most common presentation. It presents as bright red, protuberant, compressible, and sharply demarcated lesion. And or it can be described as bright red lobulated plaque or nodule. So the most common site for superficial hemangiomas are face, scalp, back, and anterior chest. And it may present as solitary or multiple lesions. And for deep hemangiomas, it is more deeply situated, more diffuse, and less defined as compared to superficial hemangiomas. And the lesions are described as cystic, firm, or compressible, and the overlying skin may appear normal in color or may have a bluish hue. And for mixed hemangiomas, it have both superficial and deep components. So these are the pictures. So for superficial hemangiomas, we can see there is a bright red lobulated lesion And for the deep hemangiomas, we can see a bluish soft tissue swelling. And for mixed hemangiomas, we can see a mixture of both components. So next, we need to know the sites of the lesion. So most of hemangiomas are located in the head and neck region, and most of them are solitary. But if there is more than one cutaneous lesion, it increases the likelihood of having visceral hemangiomas. So the primary site of visceral hemangiomas is the liver. So next, we need to know the special site or segmental hemangiomas that pose a significant complication if not treated immediately. So the first one is a bird distribution. So this bird distribution can cause airway obstruction, and it involves the upper airway or subglottic region and manifests as hoarseness of voice and stridor, and it can progress to respiratory failure. Next is periorbital hemangiomas. So it poses a considerable risk to vision. So it can cause amblyopia, strabismus, or astigmatism. Next is a segmental hemangiomas, which cover a particular section or area of skin and may be a markers for underlying malformation or developmental anomalies of heart, blood vessel, or nervous system. So the first segmental hemangiomas is face syndrome. So face syndrome is hemangiomas that involve extensive area of face and associate with multiple anomalies. So face is actually an acronym for the condition that associated with the hemangiomas. So P refers to posterior fossa, structural brain abnormalities, and H refers to hemangiomas of the face, head, and neck. So it is a segmental and more than 5 centimeters in diameter. Next, A refers to arterial lesion, especially the carotid, cerebral, and vertebral artery. C is for cardiac anomalies, such as coarctation of aorta and many other structural anomalies. And E for eyes abnormalities. So next is another segmental hemangiomas that involve the lower body area and associate with multiple congenital anomalies. So the latest association that has been proposed is lumbar syndrome. So lumbar is acronym for L is lower body hemangioma and other cutaneous defects. U refers to urogenital anomalies. M is for myelopathy, which is the most common anomalies found in lumbar syndrome. And B is bony deformities. A, anorectal malformation such as imperforate anus and arterial anomalies. R is for renal anomalies. And this association has previously been described as pelvis syndrome. So pelvis is acronym for perineal hemangioma, external genital malformation, lipomyelomeningocele, vesicorenal abnormalities, imperforate anus, and skin tag. So next is another complication that may arise, which is KASABACH-MERRITT syndrome. So KASABACH-MERRITT syndrome is a life-threatening condition characterized by a rapidly enlarging lesion, thrombocytopenia, microangiopathic hemolytic anemia, and coagulopathy. So this happens due to platelet and red blood cell trapping and activation of the clotting system within the vasculature of hemangioma. So previously, it is believed to be associated with infantile hemangiomas, but now they discovered that KASABACH-MERRITT syndrome is associated with two other vascular tumor, which are capaciform hemangioendothelioma and tough angioma. And it is not associated with infantile hemangiomas. So the clinical manifestation usually evident during early infancy, and it includes a vascular lesion, usually cutaneous, and rarely located in viscera, precipitous hemorrhage secondary to the thrombocytopenia, and a severe anemia from hemorrhage or microangiopathic hemolysis. So that's all from me. Thank you.
All right. Okay. Can we continue with the second presentation? I think we leave the question to the end.
Okay, can everyone hear my voice? Can everyone hear me?
Yes.
Okay, all right.
Yes.
Yes, tapi tak kuat sangat.
Kuat tak? Ke kena kuatkan lagi?
Okey dah kot, okey kot.
Okay, all right. Okay, so Assalamualaikum warahmatullahi wabarakatuh. My name is Nurul Fariha, and I will be presenting about atopic dermatitis or eczema. This is my outline. So based on CPG in the management of atopic eczema or atopic dermatitis is a complex, chronic and recurrent inflammatory itchy skin disorder. And according to pediatric protocol, atopic eczema also usually develop in early childhood, which follows a remitting and relapsing course. There are two types of atopic dermatitis based on clinical manifestation, which are acute and chronic. Acute atopic dermatitis is characterized by papulovesicular eruption with erythema, weeping, edema, and excoriation, whereas chronic eczema is characterized with cirrhosis or dry skin and lichenification. It is a thickening of skin and increase in skin margin. And bear in mind that severely dry skin is a hallmark of atopic dermatitis. The choice of treatment also depend on the clinical presentation of atopic dermatitis. Pathophysiology of atopic eczema is usually unknown, but there are three acceptable explanations. The first one is complex interaction of genetic predisposition. Based on study done in Singapore, 20% of patients with atopic eczema carried at least one filagreen gene mutation. The mutation of the gene will cause the skin to become dry and crack. This will lead to the entry of the allergen and initiate the inflammatory process. Thus, it will cause redness, swelling, and itchiness over certain area of the body. Besides genetic determination, eczema is also a type 1 hypersensitivity. IgE causes release of the histamine once allergen is introduced. It has been demonstrated that T helper 2 cytokine cells such as interleukin-4 inhibit the expression of filaggrin and S100 protein and thus impair the epidermal barrier. Environmental triggers also play roles in the pathophysiology of atopic eczema. The first one is prolonged exposure to an environment with low humidity that can lead to dryness. Second, the use of soap that are neutral or alkaline can cause changes in the skin pH. The third one is psychological stress that can aggravate the skin's permeability function. All of this pathophysiology will further weaken the epidermal barrier and With the breakdown of the barrier, affected skin is more susceptible to trigger factors such as irritant and allergens, which can further aggravate the atopic eczema. This picture depicts the area of distribution of atopic eczema. The distribution of eczema tends to change with age. In infants, you can see the face and scalp are prominently affected, although the trunk may be involved. Meanwhile, in older children and adults, the skin flexures such as cubital fossa and popliteal fossae, and also frictional areas such as neck, wrist, and ankles are characteristically involved. In the principle of management of atopic eczema, the diagnosis of atopic eczema is mainly through clinical diagnosis based on diagnostic criteria. You guys can refer the diagnostic criteria from pediatric protocol or CPG later. Through a physical examination, a physical assessment, clinicians classify atopic eczema into clear, mild, moderate, and severe. From here then, the clinician proceed with the management of the patient. Emollient or moisturizer is the mainstay treatment of atopic eczema. It is a topical moisturizer such as lotion or gel that improve the epidermal barrier function and dryness, leading to reduction in pruritus. NET is topical corticosteroid. It is an anti-inflammatory agent and the first line treatment which often prescribed intermittently for short time period. The choice depends on balance between efficacy and side effect. For wet rag therapy, the technique is most useful for the treatment of acute exacerbation of eczema, in which the bandage are soaked in diluted steroid cream and applied onto eczema area to reduce the symptoms. Tacrolimus is the topical calcineurin inhibitor. It is the second line treatment in children whom eczema is not adequately controlled with topical steroid. The tacrolimus is usually given to those with moderate to severe eczema. Next treatment is systemic therapy. It is also used to relieve pruritus by prescribing antihistamine or antibiotic or antiviral if there is any case of secondary infections. And lastly, phototherapy. It is a therapeutic option for patients with severe atopic eczema who do not respond or develop side effects to conventional treatment. However, the patient or parent still need to identify the triggering factors and avoid any irritant and precipitation such as rubbing or scratching, the use of soap, detergent, fabric softeners, any fabric materials that can trigger the eczema, any tobacco smoke or dust mite, and also environmental pollutants. For evidence-based medicine value of allergy tests in eczema, the investigation include serum immunoglobulin E level, skin prick test, patch test, and skin biopsy. However, there is no specific lab investigation to confirm the diagnosis of atopic eczema. As I mentioned earlier, it is mostly by clinical diagnosis in diagnostic criteria. A systemic review found lack of evidence to suggest the use of specific IgE in supporting the diagnosis of atopic eczema. The skin prick test and patch test are only useful to exclude concomitant environmental and food allergies and contact dermatitis respectively. The skin biopsy, although used, but it is used to exclude any other atopic eczema mimickers. Based on appropriate allergy testing and interpretation, allergy skin tests rely on the presence of allergen-specific IgE antibodies bound to mast cell in the skin. When an introduced allergen interact with the specific IgE, mast cells are stimulated to release their mediators, including histamine. The advantage of skin tests is that they are rapid, sensitive, and specific, safe, and relatively inexpensive per test. However, the disadvantage of skin tests are that there is a small risk of a systemic reaction. They are associated with some discomfort, and the reaction is inhibited if the patient has taken antihistamine prior to the test. I think that's all from me.
All right, okay, very good. Next.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I'm going to continue our presentation on another dermatological topics, which is scabies. So these are my outline: epidemiology, pathophysiology, distribution of the disease, management, and EBM. So first of all, let us reminisce back our preclinical knowledge on parasitology. So basically, scabies is caused by a parasite named Sarcoptes scabii varhomenes. Scabies is normally acquired either by person-to-person close skin contact. For example, people who are living in the same residence, the students who are living in hostels, the institutionalized individuals such as prisoners, and also through sexual activity. And it can also be transmitted by sharing personal items such as clothes and bed linens. However, it is unlikely with classical scabies, but it may be important for individuals with crusted scabies. So scabies is one of the commonest dermatological condition, and globally it is estimated to affect more than 200 million people at a time. So scabies is endemic in many resource-poor tropical settings due to limited access to the treatment. In high-income economic countries, the cases are usually sporadic, and the highest prevalence of the case is usually in the countries with hot tropical climates, especially in communities where overcrowding and poverty coexist. Prevalence estimate in the recent scabies studies range from 0.2% to 71%, and it is estimated the prevalence in children is about 5 to 10%. However, the most vulnerable group, the young children and elderly in resource-poor communities, is especially susceptible to in getting scabies and developing secondary scabies complications such as bacterial infection, renal problem, and also cardiovascular disease. I will further discuss this later. Here I include the recent data, and it shows that Southeast Asia is the most second highest for scabies case. Next, pathophysiology. So the main culprit, the female mite, will burrows into the epidermis, usually the stratum corneum, and it will deposit its eggs. Usually the maturation process took about 10 to 14 days. And after maturation and mating process occur, the resulting offspring will crawl out onto the skin and makes a new burrowing for the laying of the new eggs. So actually, the main symptom, the itchiness and the rashes, is due to the mite excrement that has been absorbed into skin capillaries and causes a hypersensitivity reaction. So generalized itchiness can happen, especially at night. Why at night? From my reading, it is said that our skin is much warmer at night, and thus this will produce a conducive environment for mites to do its activities. So scabies is highly contagious because infested human will remain asymptomatic for 4 to 6 weeks, which is the incubation period, and this period will still facilitate the transmission of the mites. So in immunocompetent person, usually the infested mites will be about 10 to 20. However, in the case of immunosuppression individuals such as AIDS and HIV, they will develop an uncommon types of scabies, which is the Norwegian or crusted scabies. Okay, what is Norwegian or crusted scabies? It is basically a hyperinfestation of mites, usually about thousands up to millions live mites at one time. And this hyperinfestation will trigger, will cause a hyperkeratotic or crusting skin lesion. I will show the pictures later. So this is the life cycle of the mite. So after it has been, the eggs has been laid, it will hatch about 3 to 4 days after, and the maturation process will take about 1 to 2 weeks. After mating occurs, they will crawl out and causes the symptoms. So this is, I included the diagram for the complication of scabies. So scabies can cause itchiness and scratching, and thus it will cause sleep disturbance. Scabies also, the scratching in scabies will trigger, will cause the inoculation of bacteria, especially streptococcal pyogenes and staph aureus, and thus develop impetigo. So impetigo can be complicated with deeper skin infections such as abscess, or even serious invasive conditions such as septicemia by these two organisms. So in tropical setting, individuals who have scabies, which is associated with impetigo, they are at higher risk of getting glomerulonephritis and rheumatic fever. Why? Because we know that these three conditions, impetigo, glomerulonephritis, and rheumatic fever, are caused by the same organism, which is group A streptococcal. Next, distribution of the disease. So I included the diagram. In adults, usually the most common site are the interdigital fold of the fingers, and also the wrist, hand area, the axillary area, umbilical, groin and genital area, the legs, and also the interdigital fold of the toes. So in infant, usually the whole area are affected from head to toe. The most common sites are the interdigital fold of the fingers and also the palm, and also the inside feet of the babies. So the rashes will cause a severe and intense itchiness, especially at night. And there will be, scabies has its own characteristic, which is the silvery lines on skin, which is created by the mites, which is the track-like burrow. I will show the picture later. So the rashes varies from papules, nodules, vesicles, and also in severe cases, in much more serious case, pustules. So as I mentioned earlier, infants involve all part of the body, including face and scalp. However, face and scalp are spared in adults. This I have already mentioned. Here are the pictures that I included: the axillary area, post-auricular area, face, back of the abdomen, back of the body, the interdigital fold of the feet. So this you can appreciate the silvery lines on the skin, which is created by the mites. Here is the crusted Norwegian scabies in adults, and this one is in babies. So for management, it is divided into general care and medication. I found this in pediatric protocols. So basically, first of all, we must well equip the parents with education and give clear written information regarding the treatment of scabies. So next, we must treat everyone in the household of the infected individuals and the close contact of the individual. And we can only allow patient to go to school 24 hours after the start of the treatment. The individual's clothing and bed linen should be washed with hot water or by dry cleaning. But for clothes that are not to be washed, it can be sealed in plastic bag for 3 consecutive days. Pruritus, the itchiness, may be treated with antihistamine or antipyretic if necessary. Pruritus can persist up to 3 weeks post successful treatment, even if all mites are dead. However, therefore, the indication is not to retreat treatment unless live mites are identified. Why? Because live mite is the indication of unsuccessful treatment. So any superimposed bacterial infection should be treated at the same time as the scabies treatment. Next, medication. There are several medications that are used: the topical scabicide, oral drugs, systemic antibiotics, and the others. However, the topical scabicide is the primary line of treatment for in treating scabies: permethrin, clotamethasone, benzyl benzoate, and also sulfur. However, in serious case, which is in crusted scabies, oral drugs will be given. And if there is any superimposed bacterial infection, we can prescribe systemic antibiotics and also antiseptic soaks or bath. Antihistamine is used in order to lessen the itchiness. So this I include the tables which I copied from pediatric protocols, the treatment of scabies in special cases, the clinical condition, different clinical condition will be given different recommended therapy. However, the curative treatment is only achieved by overnight application of permethrin. Here you can see permethrin 5%, which is applied to the entire part of the body. However, it is used at 1 week apart because permethrin is not effective against eggs. So it will be applied again 1 week apart to kill the subsequent late hatch larvae, sorry. On the other hand, for crusted scabies, the oral drugs will be given, the ivermectin, and there will be additional measures, which is keratolytic agent at the hyperkeratotic skin lesion. So next, evidence-based medicine. I've been given task to discuss about the role of topical corticosteroid in the treatment of scabies. So there are evidence that topical corticosteroid is used in scabies, which is to treat nodular scabies. It is basically the classical scabies. So topical corticosteroid is used in only short duration of time, according to the severity of the rashes. So the itchiness, the topical corticosteroid is also used in the treatment of the itchiness of the scabies. So we must bear in mind that the persistent itching is maybe not just because of the hypersensitivity reaction by the mite excrement, but it can also might be due to allergic contact dermatitis to the medication given, or post-cabatic eczema, or even a possible treatment failure. So I cited from WebMD, hydrocortisone cream can reduce itchiness, but it can change the appearance of the scabies rash. So it is best to be given only after we have been diagnosed, confirm the diagnosis. So just to refresh how corticosteroid affect mechanism of action of topical corticosteroid. So we know that our cell membrane contains is composed of phospholipids. So phospholipids has phospholipase. So phospholipase is responsible for the synthesis of arachidonic acid and the lipoxygenase and cyclooxygenase pathway. So steroid will inhibit phospholipase. As we know, leukotriene is responsible for inflammatory response, and prostaglandin is responsible to increase the vascular dilatation. So corticosteroid basically will cause vasoconstriction, anti-inflammation, and decrease in epidermal proliferation. So before I end my presentation, I would like to share my findings, something. Actually, dogs and cats also has their own scabies mite. However, their type of mite is not similar to humans' mite. We can get infested by their types, but usually they will die off without causing serious symptoms. So that is all from me.
Okay.
Assalamualaikum warahmatullahi wabarakatuh. Can you hear me?
Yes.
Yes.
Alright.
Yes.
Yes.
I'll be sharing about Stevens-Johnson syndrome for this time of seminar. First, the definition of Stevens-Johnson syndrome. It is a disease within the spectrum of severe cutaneous adverse reaction that is scar that affect the skin and mucous membrane. It is a rare condition that affect only 1 to 2% per million people every year. That's why we can rarely see Stevens-Johnson syndrome patient in the ward because it is very rare. It is severe and life-threatening condition and considered as medical emergency, and it can cause death if no early treatment is involved. It can affect more than 2 mucosal surface in our body, including our oral surface, respiratory, gastrointestinal, ocular, and so on. Currently, the SJS have the same clinical presentation as what can occur in toxic epidermal necrolysis, that is TEN, since both of them are from the same spectrum of the disease. Both SJS and TEN have rapidly developing purpuric macule and target-like lesion with mucosal involvement and skin detachment. However, the only differentiation of SJS and TEN is that in SJS, the skin involvement only include less than 10% of the total body surface area. And also, there is extensive necrosis of lips, mouth, and purulent conjunctivitis that you can see in SJS chart. Next is we move to the next presentation, that is pathophysiology of how SJS can occur and how the mucosal erosion in SJS patient occur. The exact mechanism of the pathophysiology in SJS is not fully understood, but since the common etiology of SJS is due to drugs, so most of the proposed mechanism is due to drugs. So first, there is binding of the drug metabolite to the HLA that present on the antigen presenting cell. In our case, the antigen presenting cell is the keratinocyte in the dermal area, and then this antigen keratinocyte detect the drug metabolite, and it decide that this metabolite is foreign substance to the body, so MHC complex 1 is formed. After that, MHC complex 1 present the foreign body to the T cell receptor. During this process, cytokine is released to promote the clonal expansion and activation of the cytotoxic T cell. After the activation of the T cell, there will be direct and indirect process by the T cell itself that can eventually cause the cell death. For the direct mechanism, the first ligand on the cytotoxic T lymphocyte, the T cell itself, bind on the fast receptor on keratinocyte. So this fast ligand, when they connect each other, it can cause cell apoptosis. After that, and the second proposed mechanism is that the CTL, cytotoxic T lymphocyte, secrete granzyme and perforin. So this can cause cell death. For the indirect mechanism, the CTL recruit other cell that release granzyme and perforin to kill the keratinocyte. and then cell death will occur. Next is the risk factor of the risk factor in SJS patient. Most of the patient in SJS suffer SJS due to the genetic susceptibility. In genetic susceptibility, patient with specific allele can make them be more sensitive to the certain drug. For example, here is that a patient with HLA-B1502 is more sensitive to carbamazepine, and HLA-A3101 susceptible to lamotrigine, HLA-B allopurinol. However, there is still ongoing studies about the type of allele that can cause the increased sensitivity in the patient. And the allele, the sensitivity of the patient is different in different country because it is due to the natural selection. For the type of drug that can cause SJS is anticonvulsant, antibiotic, and NSAID. For the anticonvulsant, the most common drug that can cause SJS is carbamazepine, phenobarbital, and phenytoin. For the antibiotic, sulfonamide, penicillin, and isoniazid. For the NSAID, phenylbutazone and salicylate can precipitate the disease occurrence. The second risk factor for the SJS is it is either due to bacteria or virus. The bacteria that can cause SJS is Mycoplasma pneumonia. This is the most common organism that can cause SJS. For the virus, the most common cause is herpes simplex. It also can be caused by enterovirus, adenovirus, measles, and mumps. And immunocompromised patients are also at risk in contracting the Stevens-Johnson syndrome. It is either HIV or AIDS patient with autoimmune disease, for example, SLE, and patient with ongoing treatment, for example, chemotherapy and organ transplant. And the mechanism of this all disease that can cause SJS is not known, but the proposed mechanism is that there is dysregulation of immune system, of immune mechanism in our body. And last risk factor is that family history. There is positive family history of Stevens-Johnson syndrome that run in the family. Okay, diagnosis of SJS is done clinically. There is no diagnostic test to diagnose SJS according to Nelson textbook. And in the study, there is the SJS can be diagnosed through clinical manifestation, and also when we see the histopathology of the lesion during the skin biopsy. During the histopathology, during the skin biopsy, there is widespread necrosis of all layers of epidermis, marked keratinocyte apoptosis, and mononuclear cell infiltration. And however, during the skin biopsy, the timing of taking the skin sample is important, because when you take the skin sample from the center of the blister, you can see the widespread necrosis that involve all layers of epidermis. However, if you take the skin sample from the margin of the blister or the erythematous base, you can only see not widespread necrosis of the epidermis. And the clinical clue that we can apply to diagnose SJS is we have four. there is the patient experience prodromal episode such as fever, malaise, headache, sore throat, cough, vomiting, and diarrhea. And the most common presentation during prodrome period is fever and malaise. After prodrome period, the patient can also have subside the fever, malaise, but also there is patient that can have severe fever and malaise after the prodrome period. The prodrome period can extend from 7 to 14 days. And there is extensive epidermal detachment of the mucosal involvement, but it need to be less than 10% of the total body surface area. And from the history taking itself, it is most commonly caused by drug administration, and the clinical manifestation can occur typically after 3 weeks, 3 weeks of starting the drug treatment. And in SJS, we can see the positive Nikolsky sign. Nikolsky sign occur when there is sloughing of the mucosal membrane. Nikolsky sign is the ability of the lesional skin to be pushed slightly aside by the pressure of the finger. And in clinical, during the physical examination, what you can do is that you can apply some pressure using your thumb at the bony prominence, and the skin can move to the side. This is the sign of Nikolsky. However, in clinical, there is direct and indirect type of Nikolsky sign. There is direct when the epidermis of our skin can be pushed aside, and in indirect, the blister can be pushed aside. So the severity of the disease can be known through the direct or indirect. When the direct Nikolsky sign is more severe than the indirect Nikolsky sign, because indirect we can move the skin, we can push the skin to the side, but in indirect we can only push the blister to the side. So it is early sign of the SJS. In early of the disease, what the mother can see in the child is that there is purpuric macule spot, on the body. There is typically present at the trunk or in face. And also we can also see the atypical flat target lesion. It is called atypical because usually typical target lesion have 3 zones, but in atypical it only have 2 zones. This is the purpuric macule spot on the trunk. This is the atypical flat target lesion. So we can see that in atypical target lesion, there is bright red center and the margin is dull. So after the formation of this lesion, the lesion rapidly evolve into bullae and the area of necrosis. Bullae is we can see that bullae is a blister with fluid fill. Bullae is a fluid fill blister. So this is the picture of the bullae. And the other clinical manifestation that include in the oral, we can see mouth ulcer and crusty lip. So the patient will have pain in swallowing. From the ocular, the patient can have photophobia, conjunctival itching or burning, and the patient can the common presentation is purulent conjunctivitis that is seen in the picture. For the urogenital system, we can see penile, vaginal or perianal erosion. For the esophageal, there is sloughing of the esophageal membrane causing bleeding and diarrhea. For the respiratory system, the patient can have hyperventilation or acute respiratory distress syndrome. For managing the patient with SJS, actually, patients in SJS are managed mostly by the symptom. Firstly, in supportive care, we need to admit the child to the isolation room. Some hospitals admit patient to burn care unit, and we need to take note that the faster the admission, the higher the survival rate of the patient. Second, the wound care. And the wound care in the SJS patient is treated conservatively. That is, if the patient have no skin debris, we do not need another dressing, because the blister skin of the patient can act as natural biological dressing that can cause reepithelialization. So we don't need any other dressing. And for the case of wound that need dressing, we need to use non-adhesive wound dressing. And if the patient experience pain at the wound, we need to give a painkiller. NG tube, nasogastric tube, or parenteral feeding is initiated to avoid a nutritional deficit, because the patient with AJS commonly cannot eat due to the erosion of the oral cavity. And soft bed is given to the patient to avoid bed sore. For the specific treatment, we need to eliminate the offending drug, offending drug that cause the SJS, that precipitate the SJS patient, and it is a priority to remove a drug when you have seen the blister or erosion in the patient's body. And drug with long half-life can induce a higher risk of mortality. So we need to have detailed history of administration of drug should be taken from the patient. And for the monitoring purposes, we need to monitor the vital sign, surveillance of the cutaneous infection to avoid secondary infection, and the fluid management and electrolyte monitoring. To prevent complication, we need to apply the wound care, and surgery only done to remove the necrotic epidermis, and refer to the ophthalmologist to avoid the ocular complication, and oral care to avoid other complication in the mouth area. And there is still ongoing debate on the efficacy of intravenous for the specific treatment of the SJS. We also have early initiation of intravenous immunoglobulin, and in the pediatric protocol in Malaysia, we need to administer 0.4 gram per kg per day for 5 days in the patient. And there is still ongoing debate on the efficacy of intravenous immunoglobulin in the treatment of Stevens-Johnson syndrome. And many studies have shown that IVIG, intravenous immunoglobulin, that started earlier in treating the patient with SJS can bring out good clinical outcome. The role of IG proposed was by the action of the immunoglobulin. The immunoglobulin block the fast receptor that present on the keratinocyte, and when the immunoglobulin bind on the keratinocyte, it can saturate the binding site and avoid apoptosis. After that, it reduces the formation of cytokine and cell death mediator. So this can reduce the cell apoptosis and promote reepithelialization and healing process. Oh, the picture I have shown here is the outcome of the patient during the first visit of the patient, and this is the final visit of the patient when treating with intravenous immunoglobulin. The complication of Stevens-Johnson syndrome include uneven skin tone, hair loss, secondary skin infection to the wound, and inflammation of internal organ, for example, pneumonia, inflammation of the lung, myocarditis of the heart, nephritis, kidney, and hepatitis to the liver. The patient can have high mortality rate due to acute renal failure, and there will patient with chronic and ulcer stricture of the esophagus, and there is chronic and stricture of esophagus and pharynx. And in severe patient, the patient with stricture of esophagus and pharynx, we need to perform pharynectomy. Okay, that's all for me. Thank you.
All right. Do you have any question to the presenters?
I have two questions. The first one regarding the eczema. Do we give oral corticosteroid in treating eczema?
Mainly we give the topical, but if it is severe enough,
So can the presenter give your comment?
mainly we give topical. It is the first line treatment. However, if it is severe enough, we can prescribe oral corticosteroid, but for a short term period of time.
Okay, any question? Anyone? Generally, there's no role of oral corticosteroid. Generally, for mild, moderate, there's no role. Even the severe one, actually, they would need more potent topical corticosteroid. Logically, because atopic dermatitis is actually a skin condition. It's not a systemic condition. So if it's not a systemic condition, like rheumatoid arthritis, so because it's not systemic, then there's no role of systemic corticosteroid.
Okay, doctor. My second question is about the SJS and TAN. How do we clinically measure to measure the 10% and the 30% to diagnose SJS or TAN?
So what's this one? What's the answer?
Usually in toxic epidermolysis, there is extensive lesion that we can see throughout the body. In the patient with SJS, we can see only in the face or in the trunk. In the 10 patient, we can see throughout the body.
But the question was, how do you assess the 10 or 30%?
I don't know. Then. Sorry,
Any
Doctor, I
idea?
don't know.
Any idea?
By estimation, Doctor.
Sorry?
Mean,
Yeah, how do you estimate? How do you estimate? You probably know this already. So the one of the management is to send the patient with IGS to where? To which what they say?
Burn care unit.
Yes, okay. So how do you assess the thing? You know, there's actually burn the diagram, right? You decide use a Parkland formula. You encounter that? Belum masuk lagi. This is your first time, okay? You can actually look at the diagram how people estimate burns. There's a formula, all right? If there's affect the palm, the body, there'll be certain percentage of burn. Okay, so you can look of how we assess a degree, percentage of burn, degree of burn. So this is the general estimation. Okay, then after that we will calculate the fluid replacement. We call it the Parkland formula example. So you will learn this when you're in surgery, in ED emergency posting. Then, okay, that's how we estimate number. Okay.
Right, thank you.
All right. Any other question?
I want to ask question about eczema. How the usage of alkaline or neutral soap can trigger eczema? Thank you.
Well, generally, because the skin epidermis has been exposed, any forms of irritant can actually exacerbate the dermatitis. Okay, so because it's already been exposed, so it's not just alkaline, basically any irritants. So alkaline is in its pure form, it will actually is an irritant by itself. Not just alkaline, so basically any forms of foreign substance during the when a person or a child has acute dermatitis. So any exposure to this irritant will then trigger and exacerbate the condition. Okay, so for I think most important actually for Steven Johnson, for you, especially when you start doing your housemanship, you should recognize, especially those who are given IV antibiotic, not just the first time. If they have a rashes, develop generalized rash, allergic reaction, develop after a form of treatment being given to them, you must observe them closely for first 24 hours. They must just progress into Steven Johnson syndrome. So you recognize them early, you should call up the senior medical officer or specialist to have a look, because we can initiate the treatment plan. Okay, that's for Steven Johnson. Recognition of allergy can progress to Steven Johnson syndrome. That's the most common. And for scabies, make sure that when you work in outpatient department later, so when patient come with very recurrent itchiness, inspect their interdigital area. Okay, and then usually, just like your presenters have shown, usually you'll spare the face. So if you have the interdigital vesicular lesion, of course, think about scabies, because this is very common. They went from one doctor to another doctor who could not recognize scabies and keep giving antipruritic or just topical lotion. If you didn't treat the scabies, the problem is actually very infectious, and it actually spread throughout the what call this household. I'm sure that some of you who lives in boarding school, in dorm, have had this kind of experience as well. So you can relate that when you see a managed patient. Okay. And what did we cover just now early on? Eczema, scabies.
Hemangioma.
Hemangioma. Okay. Hemangioma, if generally, if you see hemangioma around the midline, okay, forehead, sternum, abdomen, we call it midline hemangioma. This is actually warranted investigation like ultrasound, abdomen, and kidney, because there is an association of a hemangioma in liver and kidney if you have a midline hemangioma. So this is a take-home message when you see this case in the future. Okay, any question? All right, okay, so good. Could one of your representative email me the slides of your presentation for safekeeping? Okay.
Okay.
All right, okay, thank you very much. Assalamualaikum.
Salam.
Thank
Thank you,
you,
Doctor.
Doctor.
Thank you, Doctor. Salam. Thank you, Doctor.
Thank you, Doctor.
Okay, yeah, thanks, bye.
Thank you, Doctor.
Thank you, Doctor.
Oh.
Bye.
Bye.
Thank you, korang.
Thank you,
Good
Wawa.
job.
Wawa, kita cepat.
Wawa dah berak ke?
Tak.
Recording.
Masuk balik.
Bodoh. Sorry.
Terus leave. Jangan sembang-sembang. Baik.
Dia tu saya marah. Tahu tak apa? Apa suka sembang-sembang sangat ni? Habis dah? Keluar dah semua? Tengah rekod kan ni?
Tak apa, aku rekod ni mah, rekod ni.
Dah, semua keluar dah semua manusia?
Jantung.
Dah boleh.
Tutup.